Today I'm going to talk a bit about some of the myths around heart disease and highlight some of the key non-traditional risk factors for South Asian heart disease. I'm going to also then detail how the SSATHI clinic is personalizing the cardiac care for those South Asians, and how it's evolved starting within SSATHI, but also now expanding outside of SSATHI to something called CardioClick, where we've really tried to bring digital health into the equation to improve our outcomes. Lastly, I want to highlight the NEST program, which is our nutrition and lifestyle intervention program that pairs incredibly well with our medical program here at SSATHI to really add tremendous value to our results. And it's really exciting what I think we've embarked upon here, and we have a long way to go, but I'm hoping to tell you more about it tonight and hear your feedback and questions. Now, one of the things that I start with is the very first patient that we ever had in the SSATHI clinic, and I've changed his name, but we'll call him Samir tonight, and he at that time was 44. He's now giving away the punchline, but he is now 54, and he is a father of two, had no history of heart disease when he first came to see me. He wasn't really having any symptoms. He was occasionally saying he got short of breath, but it wasn't really consistent. He was playing cricket about 3 times a week, but if any of you have played cricket, it really does depend on what you're doing on that field. You may not be getting that much exercise, right? He was an occasional smoker, and had borderline high blood pressure, but otherwise his cholesterol profile on the surface looked fine, his basic lipid panel. And actually his primary care doctor was really aggressive and said, hey, I've heard that South Asians have higher rates of heart disease. I think you should go ahead and have an angiogram. And according to medical guidelines, he wasn't entirely wrong. Men over the age of 40 who have any sort of chest pain or chest pain equivalent might consider this option. But actually, the patient said, no, I'm not going to do that, and came into my clinic to be seen and evaluated. I looked at his family tree, and if any of you have done this before, this is a family pedigree. And when we looked at his parents, while his father had passed away from cancer, his mother had had 4 stents, and she was 70 years old. And 3 of her brothers had all died from heart attacks under the age of 60. So this looks pretty severe, and it is really sobering to see that prevalence of heart disease, but it's actually a pretty common story in our clinic. He's high risk, and he's only 44. So I asked him to do the angiogram, and he said no, and so I said, okay, well, let's give you a sense of what your risk is. And this is the traditional cardiac risk score that's used all around the world. Still used all around the world. And as you can see, the race designation is limited: white, African American, and other. I'll explain why in a moment. His risk, when we typed in all of his numbers, for a 10-year risk of events, which isn't that granular, it's a 10-year risk, it's hard to really make that impactful for patients, but it was actually on the low to moderate end, 4.9%. Now, common things being common, and heart disease being the #1 killer, over a lifetime, his risk was high, but that's true of most patients, actually. But the 10-year risk was actually relatively low, and therefore his recommendation was really not to be on any sort of cholesterol medication reduction, and he was deemed a low-risk patient. But if you looked in the bottom right-hand corner, there's actually a disclaimer, and it says that actually this risk score is, it might underestimate the risk in South Asian patients. And boy, is that true. It's actually missing approximately 70% of the heart disease risk in South Asians. It's really not accounting for many of the risk factors that we know make a big difference for South Asian patients. And yet this is the risk calculator that's available and used globally for all patients. So as you might imagine, when you start adding in other ethnicities into this model, it stops losing its accuracy. So I said, listen, you're still high risk in my book, and we should evaluate you. If you're not going to do an angiogram, at least do something called a CT coronary angiogram, which gives you a 3D representation of the heart and recreates the coronary blood vessels to look and see if they're open or not. Well, actually, he had very, very little calcium in his heart. His calcium score was actually 5. But and that's very low. It's not totally normal. Normal would have been 0, but it was low. And when we actually did the CT coronary, we found that that calcium was connected to a very large chunk of non-calcified plaque, and he had a 99% blockage in the most important coronary vessel, his left anterior descending coronary vessel. And this was a critical blockage that affected 50% of his heart muscle. So he ended up getting a stent, and I'm happy to say with medical management, he's doing well today, knock on wood. But this was our very first patient in SSATHI Clinic. Today, we're doing a lot better with preventing deaths from heart attacks, both here as well as in India. In fact, one of my colleagues, that's what I call him, is Dr. Mahadevan, who used to run our emergency room medicine program, started the first sort of modern ambulance system in India and in Hyderabad at the GBK Reddy system, and brought what is now the largest ambulance system in the world into sort of the modern era with an amazing array of technologies and call center training. Had the pleasure and honor to visit that center with the dean of Stanford Medicine to see it firsthand, but it really has made a huge difference all throughout India. This is happening now, where we are doing better at protecting patients from dying from heart attacks. But the truth is, they're still happening a lot. And so what you're seeing here are 4 Bollywood actors and actresses who, in just a very recent time period, 2022 to 2023, also had heart attacks. They survived, but now they are living with the damage from their heart that they incurred. So this is really a huge problem. When we look at the global picture, 17 million patients, this is somewhat outdated, numbers are higher now, but 17 million patients approximately 12, 13 years ago died from cardiovascular disease in India alone. Now, we're talking about a quarter of the world's population, but 60% of the world's heart disease. Some of the work published by CARE's own Dr. Palaniappan, Lata's work in California, showed that South Asians are having 4 times the rate of cardiac events, and these events are happening 11 years earlier in life. So you would think that we should do better after that heart attack. We're younger, but actually we have a 40% higher mortality from that first heart attack, even though we are younger when it happens. So what's going on, and how do we stem this bleeding, essentially, of major events happening at a much higher rate in a young South Asian population? Well, let's look at some little more data to prove that this is happening. Well, that traditional risk score that you saw, we know that the rates of heart disease are much higher in South Asians, but compared to other populations. But what are the risk scores showing? Well, as we just saw, the risk scores are almost identical when you calculate them. So the risk scores are terrible, basically, is what this is saying, in predicting events in South Asians. Even if you use the more modern QRIS-3 model, which includes South Asian corrections, it's still not showing us that difference in actual event rates. It's still missing big chunks of the cardiovascular risk in our population. Similarly here, the observed rate versus the predicted rate is much higher in South Asians, but we're pretty darn good at predicting that in white patients. So we really do need much better models that are including maybe new types of risk factors. And that was really one of the major motivations for me to start the SSATHI Clinic, because when you look across the landscape of the U.S., right now there are only 2 cardiology clinics in the U.S. that are dedicated to seeing only South Asian patients. And one is in a rural sort of suburban community rather in Illinois, and the other is SSATHI. And we need more of these. We need more centers that are really hitting the hot spots of where the South Asian patients are living and having their medical issues. Now, what are these risk factors that I'm talking about? What's the non-traditional risk that I'm speaking to? What we see here are 3 big buckets. And the first one you may have heard of before, which is insulin resistance and prediabetes. You've heard about diabetes, and that is definitely a risk factor for all patients, including South Asians. But prediabetes and insulin resistance are stepping stones to diabetes, and we are really seeing intermediate incremental risk of heart attack and stroke just from those stepping stones. So you don't even have to be diabetic to have risk. And the sad part is that most pre-diabetic patients don't know that they have it. And we see the same thing in our clinic. In fact, in our clinic, we test every patient for insulin resistance and prediabetes using a 2-hour, 4-time point blood test measuring insulin and glucose with a sugar solution that you drink. The second bucket of risk is something called inflammation. And we could check 30, 40 different inflammatory markers. And there are some centers that when they screen patients, they just do a shotgun approach and they will check 40 different inflammatory markers. But the problem is you really need to choose ones that are linked directly to heart disease, that are prevalent in South Asians. And what we've done in SSATHI Clinic is we now then whittle that down to only those that also, if they're abnormal, there's something we can do about it. And these are two examples right here on the screen. Lp(a) or lipoprotein A and apolipoprotein B100 or ApoB. You can see kind of what they are. LDL, which is you've heard of before, is bad cholesterol. ApoB sits on top of it, and it also sits on top of Lp(a), and it helps to kind of shuttle some of these particles into plaque and help plaque grow. So these are the kind of two culprits that are rarely tested for in the general population, but every patient in SSATHI gets this tested at least once. Lp(a) is genetically mediated. ApoB, there is some genetic linkage to how much you have in relation to LDL, but it largely tracks with your bad cholesterol levels up and down. Now the good news is that we can actually treat this. If we lower LDL in a patient, we can lower ApoB. But with Lp(a), it's genetic, and if we try to lower LDL, we will still have high levels of Lp(a). But right now, we're testing new treatments that can specifically lower Lp(a) that will read out probably next year sometime. And so there is a lot of hope on the horizon for the South Asian population, and I'll explain why when you see the impact of these two risk factors. So, Lp(a). If you have high levels of Lp(a), again, a genetically mediated risk factor and elevation, your risk of having a heart attack on average goes up by about 2 to 2.5 fold compared to baseline. That's MACE events or stroke, heart attack, cardiovascular death, right? So you're seeing big jumps as the Lp(a) goes up compared to your baseline reference levels. But not as much as it does when ApoB goes up. If your ApoB level is high, your risk can go up 6-fold. And so that sounds like a lot, and it is. If you compare that to diabetes, which everyone thinks is a big risk factor, and it is a big risk factor for heart disease, your risk factor goes up by 1.8-fold. We're talking about now 2.5 for Lp(a) and 6-fold for ApoB. These are much more potent risk factors in many cases than all other risk factors combined. And yet no one's checking for them routinely in South Asians. So we've started to do that from the very beginning of SSATHI. Back in 2014 when we launched the clinic, we started checking for Lp(a), checking for ApoB. Now the prevalence of elevated Lp(a) levels is dramatic in South Asians. The median value of Lp(a) is about 40% higher than the upper limit of normal for Lp(a). So at baseline, we as South Asians have a genetic predisposition to have high inflammatory levels. This is similarly true with ApoB, but the good news with ApoB is we can actually lower it. With Lp(a), we're waiting for that treatment, but it does impact how aggressive we are with our treatments. And so SSATHI has really been thinking about this for a while, because if you're sitting here in the audience right now and you've never heard this before, you're probably somewhat depressed. And you're saying, I'm South Asian, what can I possibly do to help lower my risk? We started the Stanford South Asian Translational Heart Initiative in 2014 to do personalized risk reduction. And really the way it's set up is a 6-month program, and I'll explain what CardioClick is in a moment. A 6-month program that actually has 2 to 3 physician visits, 2 to 3 dietitian and lifestyle intervention visits with baseline and follow-up labs, and we're doing that non-traditional risk assessment. Seeing 1 or 2 of the doctor visits, sometimes 2 to 3 of the dietitian visits, and they weren't getting better. They weren't reducing their risk. We were only converting patients to a lower risk level 40 to 50% of the time, and that wasn't good enough for me. So in 2017, we realized through surveys and just observation that patients just didn't want to commute. Many of them are young, professional. They didn't want to leave their parking spot at Google. They really didn't want to come in person that many times in a 6-month period. Not unreasonable. So I launched CardioClick at that time, which is a fully virtual form of the SSATHI clinic. We actually started it for return visits initially, and when the pandemic started, that was the model that Stanford Healthcare used across the enterprise to actually virtualize care when everyone was in lockdown. They used the CardioClick model. So what is SSATHI? SSATHI is a targeted heart risk assessment program to move the needle on this epidemic. We start by checking these non-traditional risk factors. I mentioned the glucose tolerance testing, the inflammatory panels. We also do particle sizing of lipids because not all LDL is bad, not all HDL is good, but we tend to have bad proportions of each as South Asians, and we need to know what our natural set points are. So we use these non-traditional risk factors along with the traditional stuff, high blood pressure, diabetes, smoking, obesity that you've all heard of, to actually craft an actionable plan. We do an adjusted risk score for patients that we think captures the rest of that curve that you saw, that difference in predicted versus actual event rates. We actually create our own risk score that trues that up to what we think is actually going to happen to our patients. And we have our own algorithms to combine the non-traditional and traditional risk into an actionable treatment plan. That includes always diet and lifestyle treatment in terms of recommendations for changing one's diet. This might be lower carb intake, caloric intake, intermittent fasting. It could be increased protein intake. And it might include a specific type of exercise like resistance training in proportion to cardio that we think is going to be better tailored for that individual patient. It also includes medical therapy decisions. As I mentioned, apoprotein B can raise your risk by 600%, sixfold, right? Whereas diabetes might only be an 80% increase. But if someone has a normal LDL, normal cholesterol panel, which most of our patients do, but their ApoB is off the chart, we will actually treat them with a statin to lower their ApoB because we don't care about the LDL. We'll treat through the LDL to the ApoB because we know it's going to come down. We also have a very low threshold to do stress testing or CT scanning, and we actually started doing more calcium scores. We now have moved to doing more coronary CT scans. In Europe, it is actually, in the UK particularly, it's a first-line treatment to get a CT coronary angiogram, which is a non-invasive test, but it gives you the anatomy that you saw in that first patient. We're able to see through that and sort of create a better representation of whether they actually have disease, because a lot of these risk factors that you see above are just, they might have disease or they might develop disease. The CT scan is saying, yeah, you do have disease right now, and we need to treat you differently or more aggressively based off of that. Still need to focus on those risk factors, but how aggressive are we going to be in managing those risk factors, right? So that's where we've developed that kind of pattern and sort of care pathways for our patients. So is it working? And the answer is yes, it is working. And if you look at our in-person versus our CardioClick, so we are doing well in the in-person cohort in the lighter gray bars here in terms of reducing blood pressure, cholesterol, hemoglobin A1C does go down, but not that much. Didn't make a lot of changes in the weight because of that traditional program was kind of losing its power. But with CardioClick, that telemedicine version of SSATHI, we actually had significantly better results in bringing everyone's risk biomarkers down. This was really gratifying, and we see over 90% of our patients reclassified to a lower risk level in 6 months, which is really something we're very proud of, very impressive. So I really want to emphasize, like, as you're looking at this information, like, what should you do? If you haven't been screened for your South Asian specific risk factors, you need to do that. And not just you, but your wife and your husband and potentially your children, depending on their ages and stages of life. If you have a family history, which many of you do, of heart disease or stroke, this is even more important. So getting your family screened, getting yourself screened is the first step. The problem with giving a lot of information is if you don't give guidance of what to do with it, you leave patients in the lurch, I think. You have to have a clinic that's going to do something with the information and make the information that we're getting actionable. And we do that in SSATHI, where we're tailoring diet and lifestyle program and medical therapy through algorithms that we've thought sort of deeply around and are always changing, actually. And then lastly, we are more aggressive with imaging, and the CT scan I mentioned, looking for actual coronary disease, will supersede your risk biomarkers every time. They're not perfect in predicting your risk, and so looking for the disease is often something we do. Finally, the American Heart Association, the American College of Cardiology are including South Asian ancestry as a risk enhancer for whether someone should consider treatment. It's still not particularly prescriptive. It's kind of left to the clinician to do with it what they will, but at least they're thinking about it. I think we need to be more aggressive in getting some of these solutions out into the market. I think Nithya mentioned that I have a company I started that looks at software to use the patient data in the chart to better match them to the right treatments at the right time. And this was really born out of this clinic, where I was seeing so many patients who should have had simple risk factors treated, but also non-traditional risk factors tested for at least. And that's something that we should be doing across the board in medicine so that patients don't slip through the cracks. And so that's what we're doing in SSATHI and CardioClick.